One of the most challenging aspects of our job is that we are overflowing with good news stories from around the world. How lucky are we? It's hard to believe, but even after a call with partners in countries like Burkina Faso that is plagued with civil conflict, or Sri Lanka that is enduring a catastrophic economic crisis, we are left smiling and full of hope. To share some of this infectious positivity with the world, we created the Good News Podcast, a platform where our local leaders get to share what they are working on to improve some of the issues unique to their communities. In today's episode, I speak with Anne Kramer from Maya Health Alliance about their Indigenous-led healthcare initiatives and how they are getting vital health information and services to ethnically and linguistically diverse communities in some of the most remote parts of Guatemala. We also discuss the power of multi-year funding and how it allows for long-term, sustainable planning for not-for-profits. Anne and I cover so many topics in our conversation that this episode is a bit longer than usual. So make a cup of tea or tie up your walking shoes, hit play, and enjoy this incredibly inspiring discussion. Today, we're talking with Anne Kramer, the Executive Director of WUKUKUAK, also known as Maya Health Alliance. Maya Health Alliance is addressing a really critical health need in Guatemala, and that is providing healthcare to underserved communities, especially through Indigenous-led healthcare initiatives. Their programs include child nutrition, women's health, family planning, maternal infant health, and chronic disease. Maya Health Alliance often says, where others say no, we say yes, which is really a testament to the fact that their Indigenous health workers are truly serving some of Guatemala's most remote and underserved communities. Welcome, Anne, to our Good News Podcast, and thanks so much for joining us. Many of our listeners have probably not been to Guatemala, so I'm wondering if you can set the scene a bit. Can you describe what a typical morning looks like? Do you have coffee or tea? Or are there sounds or smells that really define a Guatemala morning?
Yes, thank you. I think here in Guatemala, it's a really brilliantly colored country. It has fantastic colors and weavings, and the streets are full of people who are, busy about their morning schedules. Where I live in my community, we are able to listen to a lot of birds, which is really fantastic. There's lots of tropical birds early in the morning, and I love to drink my coffee and listen to the birds early in the morning. But I think notably here in Guatemala, people are surprised by the noise and all the colors and the buses. It's a really lively country. It's extremely beautiful with volcanoes and mountains and lots of tropical flowers and plants.
Oh, wow. That sounds like a pretty cool place to have your morning cup of coffee. Can you tell us a bit about how you ended up in Guatemala?
I came to Guatemala almost 20 years ago when I was a graduate student, really interested in studying Guatemala and understanding why does Guatemala have so many nonprofits. At the time, almost 20 years ago, there was over 20,000 nonprofits in Guatemala. And, I really wanted to understand why are there so many nonprofits in a country the size of Ohio? Yet there doesn't seem to be a lot getting better, if you look at indicators of education and health and women's rights. And so I really wanted to understand this. So I came down originally to really kind of critique nonprofits, understand them better, understand what was happening on the governmental level. I came down as an early graduate student over 20 years ago as an anthropologist wanting to learn.
Oh, wow. Interesting. And where are you from originally?
Originally, I'm from Cincinnati, Ohio.
Sometimes there's a hesitancy to work with local organizations that have a director that's not perceived to be local. I would really love to hear from you what your thoughts are on what is local.
It's a great and important question. I think that's something that I myself hesitate to always know and understand as someone who's lived in Guatemala for almost half of my life. My children are dual citizens of Guatemala and the United States and are half Guatemalan. And I think local really becomes a context of understanding and really being able to voice what the community needs. I myself work with a team who is 96% Guatemalan. So our team has majority Guatemalan people from the communities. Yet I'm here. I was called by the community to come work with the community to help, to bring my knowledge to the table, as well to reach out to Americans, to people across the world who are not in Guatemala and who may not understand what's happening here. And so that's a big role of mine, to be someone who can help bring people in to understand Guatemala, to speak English. I also speak Spanish. A lot of people here in Guatemala don't speak Spanish. They speak one of the 22 different Mayan languages that are spoken here. And when you look at community work and what needs to happen, my job is to really echo their voices and make their voices louder. So, am I born and raised in a rural Indigenous community? No. But have I spent 20 years of my life here working with communities, listening to them, helping them, make their voice louder? Yes. I believe that we are doing the work of the local communities. And while I might not exactly look like and represent that community in that way, I think there are people who can work with teams. It takes really a community of people to come together to make local work happen. And I think that's what's important for people from the outside is to really dig in, understand the group that you want to support or know more about. What's really happening? What does local mean? For someone like me who's committed to Guatemala, my life and being here, I think it's important that other people can dig deep and see the Indigenous communities that we're working with need their help. And if I'm not here to maybe help and speak English and reach out to those people, they wouldn't receive funding. They wouldn't receive, access to care. And so that's what I'm driven to do. And it takes a team of us to do that. So I think it's important to look local and understand organizations that are able to really understand and have the pulse of what's happening in the community. But I don't always think that it has to be that one representative from that local community that is speaking. I think it can take a community. It takes a real network of all of us to help raise their voice.
Absolutely. Well said. Thank you so much for your willingness to talk about that. I know that's something that you and I really share in common, that I have Kiwi kids. Sometimes I have this kind of insecurity of like, am I a local? As the world becomes so multicultural and there's so much movement, the question is like, what does local even really mean anymore? I think for us at Move 92, we really engage in these conversations because all of us have lived in a lot of places around the world, feel deeply connected and passionate about certain communities. So thank you. Well, let's shift gears and talk about Maya Health Alliance because, gosh, we could certainly spend a full day talking about the incredible work that you're doing. Before we do talk about the programs in particular, can you tell us what the name means?
Yeah, so Wukukawok is our name in Kakchikel Maya, one of the 22 Mayan languages spoken here. And it's a day in the Mayan calendar, the traditional Mayan calendar, which usually a Mayan family would name a child or an organization after the day it was born. So we as an organization began on January 1st, 2007, which in the Mayan calendar was Wuku Kawok, or 7, and then the day of midwives and healers. And so we chose that day to really reflect who we are and the work that we're doing, and that we came from the Kakchikel community.
How interesting. I know for myself, the more that I've worked with organizations in Guatemala, the more I learn about the cultural nuances of the indigenous communities. Can you share a bit about how that impacts healthcare delivery specifically?
Yeah, you know, Guatemala is a really unique and special country in that it has so much cultural diversity and language diversity, and it makes it so beautiful. And it's very mountainous. It's extremely hard to get from one place to another. We don't speak in miles or kilometers, but we speak in amount of time that will take to get somewhere,
Hmm.
because the roads can be so difficult to travel. And while it is so beautiful, at the same time, that can often mean a lot of disparity and a lot of discrimination and a lot of really difficult situations, especially for women and children in this country. Oftentimes, what it means is a lot of women and their families live in very remote communities, and getting to healthcare can be very difficult. Walking to get to healthcare, not having bus fare to get to healthcare. And due to a long, really difficult 36-year civil war that happened here and ended in 1996, there's a lot of mistrust from community members towards the government, towards outsiders. There's a lot of fear. Unfortunately, that civil war was called a genocide by the UN. And a lot of women who don't speak Spanish, they may speak their traditional language, it can be really hard to go and take that long trip and get into the health post and talk to someone who doesn't speak your language, who may not understand where you come from. And oftentimes they can be treated
Mm.
poorly because there's a lot of discrimination and racism. Really, I would call it an unknowing, a misknowing between healthcare providers who come from often Guatemala City or the urban centers, and women and children and patients who come from rural, remote communities, traditional communities. It's really an unknowing of who is the other, but that often, transcends in discrimination and racism and mistrust. So for many women, children, communities, they feel locked out of their healthcare here.
It's so interesting that that happens in one country, that this isn't like refugees or migrants coming in. These are actually all Guatemalans, but coming from such different cultural places and language barriers that the healthcare system can't reach a whole population in its own country. Language, especially, is something that it sounds like is one of the greatest barriers. And I know that one of the programs that you have started, I tell this story quite a bit about the mobile app.
Mhm.
Can you share a little bit about that?
Yeah. Language is a large barrier here. And the way that we try to look at the work that we're doing is we want to reach our patients where they are. We want to help patients receive the care that they need in their language and in their culture. Our goal is to cover these gaps in care in Guatemala. And there's a really large gap here in maternal health. Unfortunately, Indigenous women here are 3 times as likely to die in childbirth than non Indigenous women, which is 16 times more likely than the United States. So maternal mortality here is very
Wow.
high. And it's something that we are really trying to attack and understand. And in order to do that, we need to really understand culturally, how do women want to birth? What does that look like? Where do they feel safe? And when, we were doing some of
Mm.
our early work and research and talking with communities, I'll never forget it when I had more than one person tell me, I would rather stay at home and die than go to the hospital where I'm treated so poorly and I'm treated like trash. That someone would rather stay home where they're with their loved ones and may not make it, but that they feel safe and they feel that they're surrounded by people who care and can speak to them, than go to a hospital where they're just in a hospital ward hallway and no one can speak to them in their language and they're sort of just cast aside. So when there is time, they can be attended. That for me was really striking. How can we bridge that gap in care? How can we make something where people want to be in communities that are worth living in, a system where they feel safe? So looking at maternal mortality, a real problem here, we started working with midwives, traditional midwives here in Guatemala, who tend to learn through being apprentices from other midwives. They do receive some courses from the Ministry of Health. Most of them are registered as midwives, but they often work with women in their home. So women birth at home. And unfortunately, what has happened in the past is that when there's a complication in birth, it's detected maybe too late. Maybe they get to the hospital,
Mm.
but things aren't happening as fast as they should. So what we wanted to try to do was to help midwives detect when there's a high risk pregnancy and to get them to the hospital on time. So working with midwives together as our end users, we with Emory University created an application that works on an Android phone. And the midwives were totally key in helping us pick out drawings and doing the entire application in their language, in Kaqchikel, in a picture-based format that they can choose the different, images on the screen, listen to someone in their community speaking to them in Kaqchikel to kind of run through a checklist as to see if a woman might be having high-risk pregnancy symptoms, and says a lot of swelling or a headache or double vision. And as the midwives is running
Mm.
through that checklist, our on the call team of 24 hours a day would receive an SMS message or a direct phone call saying there's an emergency, there's a problem. And then our team gets on the phone, talks with the
Mm.
midwives, and we establish if that patient needs to go to hospital or not. And I think what's been really key is technology is very important in healthcare. But one key piece is that over time, as we studied this, we saw an uptake or more referral when we started using the application with midwives, but we saw a really large referral to the hospital and really saw a difference for women when we had a care navigator who then met the woman at the hospital or rode along with her on the way to the hospital. And this care navigator speaks her language. She goes in as an advocate, and she's with the woman in the hospital. Because can you imagine, here in the public hospital in Guatemala, the woman has to birth alone. She can't take her midwife. She can't take her husband. She's alone. I can't imagine the fear, what that feels like. And so our care navigator is there to speak her language, speak with the doctors and nurses, hold her hand, advocate for her. And so we've seen a really fantastic trend in lowering maternal death in the region that we're working. So it's really exciting to see something that brings culture and language and technology together to solve the problem for our patients.
Wow, that is so powerful. Gosh, I just keep thinking like I had preeclampsia with both of my pregnancies and required a tremendous amount of emergency medical care. And it wasn't lost on me, especially with the birth of my second daughter, sitting in the hospital, just really thinking because of where I live and because I can speak a similar language, that I was able to navigate this quite seamlessly. And I spent days laying in the hospital bed thinking of so many women that would have died in my same circumstance because of where they live and the languages they speak. I remember feeling a really strong personal connection to this app and the work that you do, knowing that if I didn't have the geography that I was born in, it would have turned out a lot different. And I think a lot of women can really relate to that. The number of times that we have depended on the healthcare system and kind of taking a moment to pause and realize the availability and the accessibility that we have. And some women don't have that. So I guess the other side of that is the work you do with infant health. So there's of course there's so many different phases. There's the family planning, and then the maternal health, and then the infant health, and then the child nutrition. Can you share a little bit about kind of what once the baby is born, then what?
Yeah. So, that's another whole piece. And we're working hard to really support mom and baby right after the baby is born. That's something we're also trying to focus on is reducing neonatal death through supporting, the mom and the midwife in those first several days and making sure the baby is checked on, that it's growing well. Because as you say, preeclampsia is a big risk. Also having babies who are born too small is a big risk in the home. And so we want to make sure that the baby and mom are receiving everything that they need, or if they need to be referred to hospital. In the first couple of days, we also work with moms on lactation consultant. I'll personally say breastfeeding was one of the hardest things I've ever done in my life. I think I cried more than the baby. So, that's just natural for women all over the world. I really thought it was going to
Mhm.
be easy, and it's not. And just like it happened for me, it
Mhm.
happens for women everywhere, including in rural Guatemala. How do you get this baby to latch? How do you know when they're getting enough
Mhm.
milk? And so we work a lot around that. Is baby getting enough food in the early days of life? Are they breastfeeding okay? And then as the baby
Mhm.
grows, we work with communities and families and parents that if a child is malnourished, we'll enroll them in our program. Unfortunately, in Guatemala, one in every two children here are malnourished.
Oh, wow.
We, yeah, it's really horrible statistic for Guatemala. We have the worst rate of chronic malnutrition in this hemisphere, and we're about fourth or fifth worst in the world. And so I think what's important about it is that it's a social disease. There's not one pill, there's not one quick fix to fix chronic malnutrition. We really have to fix a lot of things, access to education, access to clean water, access to better toilets, better income, and helping families having a dietary diversity that will help their child grow well. So here in Guatemala, chronic malnutrition often means that a child is short for their age. And often what that is happening is between 0 and 2, a child is not getting the right nutrients to grow well. And so oftentimes what that means is when their brain needs all of the best nutrients to grow, because it's growing the most those first 2 years of our life, the child's not getting that. And so oftentimes that can lead into having trouble to read and to walk and to focus in school. And really over a lifetime, they can have, could have less possibilities for earning income over their lifetime. And so for us, if we want to work at poverty, we
Mhm.
want to help children in their first 2 years of life. So in our communities where we're working, we weigh and measure our children and check on them for chronic malnutrition. We do have some acute malnutrition, But mostly what we're doing is we accompany families for 8 months when we have a chronic malnourished child to help them with education. It's really, personalized care, going to the home and providing them supplements when needed so that the child can grow and get back on the growth chart. So hopefully we can set them up for success to be
Mm.
able to focus in school and in their future life.
Wow. So I said it before, every time the stats from Guatemala to me are just staggering. And I think it's really interesting. I just spent a week or so in Sri Lanka. I'm kind of having parallel thoughts between Sri Lanka and Guatemala and some of the other countries we work in that they don't fall into this category of like, oh, that's a developing country. That's a country that has a lot of needs and a lot of staggering statistics. But but the more I learn about Sri Lanka and Guatemala, it's fascinating to know that these issues are so widespread and dire. So that child malnutrition statistic is it's shocking. And the other thing it makes me think of is like a lot of aid organizations or social enterprises, I think, kind of the business world that builds good into their business, talks a lot about poverty alleviation and how there's really no one size fits all. And how fascinating that what you're doing is really looking at this 0 to 2 and childhood, that actually to look at poverty alleviation, you need to start at the beginning.
Yes, definitely. And I think that's really, really key because I think sometimes we look at school lunch programs, which are important too, but we really need to focus on those first 1,000 days of life. When mom is pregnant, when the baby's starting to form, when the baby is born, what's happening during those first 2 years of life is so crucial. And again, as you talk about what's happening here in Guatemala, another specific statistic is that it is every 1 and 2 kids is malnourished here, but when you go to rural indigenous communities, it's 80 to 90% of children are malnourished. So it's really become the new normal. And that's really just the situation, even though it doesn't have to be that way. And we can make a difference. We know we can lower malnutrition by 20 to 30 to 40% with these types of interventions, but it's hard to get everybody on the same page, everybody moving in the right direction. Poverty alleviation is very hard, especially in malnutrition when it's not just a simple fix. It's about water, it's about education, it's about access, it's about food diversity. I think Guatemala is usually recognized as a middle income country because in itself, Guatemala is a
Mhm.
fairly wealthy country when you look at it in comparative to its neighbors. It's the wealthiest country in Central
Mhm.
America, but importantly, Guatemala is one of the most unequal countries in the world. And so while there is a lot of wealth in the country and there's a lot of exports and there's a lot of agriculture, the Mayan communities, which make up 40 to 50% of the population, most often are living on only a couple of dollars a day.
Wow. I'm also thinking if you look back at how My Health Alliance started, and then almost like the more you learn, how do you know when and where? I mean, it just must be so difficult to know when and where to stop the work that you do because you can't say yes to everything. And when you talk about child malnutrition and you talk about access to safe water, the reality of diarrheal diseases is such a big deal for these little bodies to keep weight on as well. How do you choose? Do you partner with other organizations that come in for water and sanitation, or what do you do when there's so much need?
It's a really great question because we cannot say yes to everything, and we can't do everything, or we're not going to do anything well. So I think we've really
Right.
committed to focusing on healthcare, focusing on chronic disease. We use chronic as sort of anything that lasts over a day, such as malnutrition, pregnancy, things like that. Areas that the government itself, what the Ministry of Health provides, needs help in, or there's large gaps in care. And we believe partnership is absolutely fundamental. We cannot do this alone. We rely on partnership. We work with other institutions that do education work, that provide clean water, that do economic jobs for women. So we can't do it all, but we can partner with a lot of groups that can help provide that. We have a large partnership with a women's finance institution. They provide finance and jobs and education and information, and we provide a preventive healthcare package focused on women's health, family planning, cervical
Mm.
cancer. And for us, that's a total win-win.
We see that a lot in a lot of the countries that we work in, that The deeper you go into the communities, the more you see, and then you kind of have to set these boundaries. And then through that boundary is then when you build partnerships, hopefully,
Mhm.
to address the coexisting needs. Do you have any specific stories you could tell of women that have really been impacted by your work?
I'd love to share a couple that stand out in my mind. And one is this woman, her name is Johanna, and I had met her specifically in one of our remote communities of a department called Chimaltenango here. And, she was coming to ask for birth control, really family planning. She herself was one of 12. And she said her mother had lost a few babies too. She wasn't really sure how many pregnancies her mother had had, but she was down towards the end of the 12 children. And she said how hard it was growing up, that her parents really didn't have a lot for them. And, she had to
Mhm.
stop her education around second grade because her parents didn't have enough support. And most of the boys in her family got the support to kind of continue on to go to school. And so by age 8 or 9, she was helping her mom around the house. She learned to weave, which most women here are incredible weavers. They do backstrap loom weaving. Often their traditional clothing are woven by hand in their home. They take a good month or 15 days to weave these elaborate, beautiful blouses. And then by 15, 16, she was looking for a boyfriend, looking for someone to settle down with. She herself had 4 kids
Mm.
already, and she decided, I, I see how hard it is to have enough tortillas for everyone in the family, and I really want to plan. My husband and I have 4. We're doing okay, but she felt like if I have more children, I can't do it, and I want to provide things that my mom and dad couldn't provide for me. And so she came to
Mm.
our women's health group, and she started learning about all the different methods. And at first, she chose a method that's a short-term acting method that's a shot, and it lasts for 3 months. And she was considering a long-term acting one, but she was a little nervous about, what does that do? What does it do in your body? But she was really happy that she could plan, that she could do the 3 months. And I think she went for about a year doing the short-term acting planning method. When she decided with our nurse, Sandy, after really working with Sandy over time, she said, "You know what? I'm going to get an IUD because then I don't have to travel all the time to come get the shot. And I feel that this will
Mm.
be the right plan for me." And I think, hearing her story and hearing her be like, "This is my decision. This is what I want to do for me." Having that trust with our nurse, Sandy,
Mm.
speaking in Kachikal, being able to, find that close to her house, that service was really rewarding and really exciting for me. And that she's making that decision based upon her own life experiences and working with our nurse to find which method will work best for her.
That is such a cool story because it's not just about access, it's about her choice and that she took the time to learn what the options were and what was going to work best for her. I am just so passionate about access to family planning. I want to just gather so many stories to kind of destigmatize it. I find that people talk easily about poverty alleviation, women's education, women's empowerment, more women in leadership roles, but none of this can happen if women don't have access to family planning and the ability to choose what their families look like. So that story in particular is really unique that she tried a couple different things and found what was right for her.
And I think that's something that I really loved about our work is that, we really focus on being able to provide long-term follow-up care with our patients. So by using our database and our EMR, we're able to reach back out to patients and say, "Hey, we know that you're enjoying this method. Are you interested in another one?" Or if we have someone with an IUD for several years, we'll reach out to them and say, "Hey, you're almost at the end of your IUD time. Would you like to renew or would you like another method?" And I think that's really key is that you're providing that trust-based information with women where they can feel free to reach out to make
Mhm.
decisions. I think it's cool. We have women on our team who work for our team who have decided that, I'm not ready for kids. I want to wait because I'm working, but I'm going to university on the weekends and I just got married. I have a partner. I'm not ready for this commitment for kids yet. Can I have a method? I've learned all about it. I'm here at our team, and of course, you can have a method. And I think it's really great to see all different types of women, women who are in university, women who are raising families, have that choice about what they want for their future. And I will say, it's exciting to see we have a few couples coming in together to say, we want to plan, together we want to decide what might work best. It's pretty exciting because that's pretty new for Guatemala. We suffer from a lot of machismo, or the idea that men are really in charge, which can lead to gender-based violence and a lot of difficulties. But seeing some of that change a little bit is exciting. It's slow, but it's pretty exciting.
That's really cool. These things do not happen quickly. Generational change takes generations. I'd like to kind of talk about the nuts and bolts of running a not-for-profit in Guatemala in terms of fundraising. What type of funding really makes an impact? Because it sounds like you have an organization that has to pivot and be agile with the ever-moving needs of the communities you work with.
Yes, we do. And I think the last 5 or so years have demonstrated that even more, going through a pandemic and then post-pandemic trying to rebuild through inflation and all of the things, immigration, and we're in a drought year. We have to be very thoughtful, I think, about what we need and what is going to help our communities and help our long-term goal. And I'm not gonna lie, I've been doing this for more than a decade. Fundraising is it's hard. You're building relationships with people, you're demonstrating, that we're doing the work. Here's our data, here's what's happening. And I'm excited to see this change that's been coming around trust-based philanthropy. I think that's really fantastic. Not to say there's no data. We still have data. We're sharing a lot of information, but rather than being really closed off and really having this, border wall of you just have to send us paperwork, we never talk to you. Trust based is really focused on conversations about learning together. We can reach out and say, hey, this didn't work out as planned because the government had a big shift or the community had a shift. So we're doing this now. And the funder being open to that is really exciting. And I would say on top of that, something that's really been transformational for us over the last couple of years has been multi-year commitments. I can't say that loud enough. Multi-year commitments. It has been absolutely transformational for our work. Instead of always focusing on fundraising, which I'm doing subconsciously most of the time, but it enables an organization to look up rather than always kind of having, your head down and like, we got to survive, we got to survive. We've had a couple donors give us some multi-year funding and we're like, wow, I can plan, I can do leadership training. I can look over the long term as to what our team needs. We can invest in, computers, technology, things like that. Usually you're sort of freaking out about, but being able to invest in my team is amazing because I can do more and I can do better if I can keep my amazing team here. I can promise them that they have a job, make sure I'm meeting some sort of salary, that's necessary for them to survive and them to invest in their families and them to feel cared for and to keep training them and to keep them motivated about the work that they're doing too. I think it's just phenomenal. We've been doing now 3 years of a leadership program and it's been transformational for my team. We really have the goal of investing in Indigenous women and Indigenous leadership. And we've now invested in a trainer. We've done 3 years of retreat with our entire leadership team. And we've been able to take all of them through this leadership training. And now we have new cohorts. And it's just fantastic to see where our team is going and where it's growing. And for me to be able to step back and see them taking over their programs in much new ways. So for us, it's been absolutely transformational. And, just as we've been talking about maternal health, we've been able to promise and keep that really strong tie to our communities that we can keep doing this maternal infant care that is so desperately needed.
That was so well said. Thank you. Because at Move 92, we play this intermediary role between funders and organizations globally. And what we hear from the funder side is consistently like, oh, that, they're doing such good work. How can they scale up, reach more people, get bigger, bigger, better, more. But then when the time comes to talk about funding, scaling up responsibly or allowing organizations to pause, to plan, there's really not a big desire to fund that because the funding desire is still in programs. And so we are finding it really exciting to have our partners be really honest about, yeah, sure, Scaling up would be great. Please provide the support and the time for us to do that. And you just said that so well. And I think your passion, especially for wanting to make your team feel valued and inspired to stay long term, takes planning and time and the ability to pause. And it's interesting when you bring up trust based philanthropy. Shadi Salehi is a friend of mine who's the director of the Trust Based Philanthropy Project. And she said that the multi year funding is consistently the one that's the most difficult to shift the mindset on.
I agree. And I think it's hard sometimes for funders to understand, what am I investing in? Where is this going? Why multi-year? And I hope through time, through trust-based, through conversations, people can see, what they're investing in, and what they're going to get, and how it enables an organization to really take that deep breath and think about where they want to go and what's happening, rather than just focusing on the survival piece of, I need this funding, I need this funding. And maybe it contributes to mission
Mm,
drift. Maybe it contributes to maybe doing things they wouldn't normally do because they're trying to keep staff on board or trying to keep programs going. And with multi-year
mm,
funding, you have that confidence to say, yes, we can do this. We can do, leadership trainings. We can invest in our staff and our communities, et cetera. And, even if it's just a 2-year piece, 2 to 5 years, it really makes such a difference for especially the work we're doing here in communities, trying to be agile, really adjust to what's changing worldwide, climate change, migration, all of these things are being thrown on us constantly. And if we don't have the funding to
mm.
adjust, we can't serve our communities.
Yeah, absolutely. So I'm curious, what question do you want to be asked, or do you want to share people that you feel like people don't tend to ask you?
I would think it's a funny question, but it's something that some people have hinted at, but maybe never asked straightforward. And it's really about what keeps me going. Why am I still here
Mm,
17 years later? There's been years where it's really hard. There's times when you're not always sure, are we going to get the funding? Can we move forward? We've grown as an institution a lot over the last couple of years. So what
mm,
keeps me going, I think, our team, our patience, and a hope, a hope that there is a future that is better and that we can get there. We need partnership. We need to create communities worth living in. We need to empower women and girls to really create that change. And in seeing some of our staff who started with us years ago, and seeing them come in and be really quiet. They worked maybe as a nurse in a hospital, and hospital systems can be kind of tough. They didn't want to speak up. But over time, through a community that was inclusive and that we try to create a safe space, you see this nurse grow, and then maybe she decided to go back to school. And over time, she's become a manager and a director for a program. And now she's at the table making decisions for the communities, making decisions for that program, telling doctors and PhDs at our team, this is what's going to happen. This is how it's going to roll, and I think we're going to bring in, this type of work for cervical cancer and these type of ideas for family planning. That for me is fantastic. Like, she's bringing home a paycheck. She's investing in herself. She's investing in her family. She's investing in her community. She's Guatemalan. She's Kaqchikel. She speaks the language, and she's driving change. And for me, that I think keeps me going, are those amazing success stories, and seeing that really transform the community, transform her. Because I always get this question, what is sustainability? Is for me, sustainability as an institution is creating nurses like the one I'm talking about, is creating people in
mm,
Guatemala who care about their communities, who are empowered to drive change, and who have the skills to do it. And so we as an institution, if we have to close tomorrow, I know that we have 105 staff in this community, in this country, who are amazing change makers and who are going to be leaders in their communities and hopefully in the country to keep driving change forward.
mm. What a hopeful message.
Thank you.
Is there anything that we didn't cover today that you still wanted to talk about? Or any lingering stories that you want to tell, or yeah, anything else before we close
Yeah,
off?
I would love to touch on cervical cancer. It's something that I think a lot of
Mm,
people especially in developing countries, take for granted because it's really something that we can prevent, that we can detect early, and that we can get care for. And in developed countries in Europe, in the United States, Canada, places like that, most women are getting their pap smears or HPV screening regularly. It's just sort of what women do. We're able to detect it early.
Mm.
And rarely do women die from cervical cancer in developed countries. In Guatemala, unfortunately, cervical cancer is one of the top leading cancer deaths for women.
Mm.
And it's directly related to lack of access, lack of health education, lack of a woman being able to make the decisions around her body. Oftentimes women will tell us, well, I have to ask my husband if I can get a pap smear, or I'm scared to get a pap
Mm.
smear. Isn't that where they take all the things outside of your body, put it on the table, and then stuff it back in? There's a lot of myths.
Oh.
Yeah, a lot of lack of education. And so when we can provide that care for women, it's transformational. And when we do find cervical cancer, we're able to get them care within the public system, within our system, in order to make sure that they're doing okay. Right now, we're in a big transition to moving away from pap smears towards HPV screening. So HPV screening has become really standard of care in many developed nations, and it is more expensive, but it is much more like a crystal ball to sort of detect if a woman's going to get cervical cancer or if she has cervical cancer. And by doing that right
Mm.
now, we're going to be helping a new generation of women, we hope, detect cervical cancer in time. We can do treatment in their home with thermocoagulation to treat, early cervical cancer lesions. We're taking steps to being able to do colposcopies in remote villages. And I think it's really revolutionary to see where we can marry and bring together, technology, state of the art care, and do it for women who are living on less than $1 a day, because they have every right to the best health care that every woman does in this world. With the vaccine, it is now available in the health centers, but there's a lot of taboos around it or total misinformation. People haven't heard about it, or, oh, it's meaning my daughter's
Mm.
going to have sexual relations and she's only 11. No, that it's not that. We're talking about prevention. But there's a long way to go to
Mm.
really talk about prevention in Guatemala. So it's baby steps. I think that's something that I'm really excited about, the work that we're doing and helping women learn about the HPV vaccine to get their children vaccinated. So it's exciting to see women talk about
Mm.
that with their children and hopefully preventing that as a future situation here.
That's so interesting. Thanks for sharing about that. Is it difficult to find funding for it because of the controversial nature?
I would say in a couple of years ago it was, but in the last couple of years, we've been able to find funding. We found people that are really behind this and really focused on this gender equality piece, this equity piece. If we can provide healthcare to women and girls, we can really transform families and communities. Because if they're healthy and if they're able to care for their family and they're able to bring jobs home and money home, you really can see a major change.
Mm. I love that you keep bringing it back to that bigger picture, that a good way to shift that stigmatization is if you want to have conversations around poverty alleviation and educating girls and women, a lot of it comes down to access to the healthcare that's relevant to right now in their lives.
100%. Unfortunately, here in Guatemala, I think it's around still Indigenous women as a whole country only graduate second or third grade or finish second or third grade in primary school. So, as a country, we have a long way to go to help women access education. And to do that, we have to
Mm.
overcome a lot of stigma, a lot of machismo, a lot of barriers to access. And healthcare is one of those, because if mom isn't able to work, if mom is sick, that little girl is not going to school anymore. She has to step up immediately to help the family, to care for the family. Much more likely, they're going to invest in a male in the family. And that's just traditionally how things have been. But, slowly we're making some of those changes, especially when they can see people like the nurses, like Sandy, one of the nurses I've talked about, who is like a star for some of these young girls. And they can see, wow, Nurse Sandy has all the information. She's making change. I can see her come and go. And she's traditional, she speaks my language, and yet look at her, look what she's doing. So I think it's really exciting, especially when we have Mayan women serving Mayan women. They can identify, they can overcome these barriers together.
Absolutely. Well, thank you so much for taking time to talk with us today. Thank you for taking the time to educate me and our listeners on the real Guatemala and what issues women are facing and that you are helping with.
Well, thank you so much, Geneva and Move 92, for really moving women and children and those issues forward, and really helping funders and others understand the needs of groups that are working on these really local issues. Sometimes our voices aren't heard way at the top, but I think it's really important that us as these local people who really care about what's happening in the communities and understand what's understanding in the communities is so important. And so thank you for being so involved and understanding Guatemala needs help, what's happening here, and seeing all of the amazing teams and work that are happening here.